here's our agenda. Again, we already covered the agenda over the next hour or so. We're going to try to keep this on time with the agenda. This is COPE-approved CE. So this is accredited by COPE for continuing education for optometrists. You are here to get one COPE-approved credit for CE. Here are the guidelines for obtaining credit. You guys are very familiar with this. Again, this is an in-person event. This will be recorded and will be available and published at the Fundingsland Group Learning Center. And again, we appreciate all of you joining us for this next hour. There's our learning objectives. Again, this is all things geographic atrophy, all things glaucoma, diagnosis, management decisions, strategies for what tests to utilize and how to detect possible diagnosis, possible progression, pull the trigger on developing strategies for patient adherence and follow-up schedule and management. As with every COPE lecture, you can see the financial relationship and disclosures. So here's our disclosures. As we go through this lecture, we're going to keep this within the guidelines of a COPE-approved lecture, a non-biased lecture, as again, we discuss geographic atrophy and glaucoma. There was a survey in 2024 through Vision Expo, Optometric survey results. They published this in July 24, or they opened it in July of 24, closed it in August 24, 132 questions. 132 questions, 310 total respondents, 94% within the United States. And we're going to show you some data over the next 45 to 50 minutes from this survey to see what about glaucoma and what about geographic atrophy. So we'll show you some of that data here in just a little bit.
So welcome and thank you for having me, everyone. So I'm going to be talking about geographic atrophy, which is a very hot topic right now. So we'll talk about that. So geographic atrophy, as we know, it's an advanced late form of dry macular degeneration, irreversible atrophy of the RPE, photoreceptors, and choriocapillaris. So you have atrophy and you lose tissue is essentially what's happening in these patients. It's a lot more common than I thought, and I think perhaps a lot of people think, because before we had a treatment for GA, we didn't really pay much attention to GA because it probably didn't really matter. Right now that we have treatments for GA, we have to start thinking a little bit more about GA. And one nice thing, in order to come up with these treatments, these companies had to look at ways to, the natural history of GA and the population studies. And we learned a lot in these studies. And one thing we learned, that it's way more common than we probably think. They say about 8 million people worldwide, and about 1.5 million people in the US have geographic atrophy. And some studies say about half of those patients with GA probably don't know they have it. So still a lot of patients have GA and aren't aware that they have a problem. About 20% of the patients with AMD have geographic atrophy. And it accounts for 10 to 20% of legal blindness from macular degeneration. And you can see here, I knew I wasn't going to be able to figure that thing out. That's all right, the button. There you go. But you can see here, atrophy here, and then over here on the OCT, we'll talk a little bit about this, but that's a very specific finding that we see with geographic atrophy, where you get a window defect or a transmission defect in the OCT. Very characteristic. I'll show you that again in a second. So he was talking about the study that we did, and we did this study, and they asked people, how many patients do you see on a monthly basis who have dry AMD? And you can see the results here. And about half the patients saw between 1 and 20 patients a month with dry macular degeneration. If we extrapolate that back, about 20% of patients with dry have GA. That's anywhere from 1 to 4 or 5 patients a month with geographic atrophy. So again, not a small number of patients that we're talking about. There's a lot of different ways to look for geographic atrophy. Some are better than others. In a perfect world, we use them all, right? Whatever you have in your toolbox, use every tool you can to look for geographic atrophy. Color fundus photos, right? Ubiquitous. Probably all of us have color fundus photos in some way, shape, or form. It's good for detecting later disease. Sometimes you can miss very subtle early disease by only relying on color fundus photos. So, not my favorite. You can see there the OCT, and oh, I had it, son of a gun. No, I want the little laser pointer. Double click, oh, son of a biscuit. Okay, that's all right, I give up. On the top, I'm not buying one of these, by the way. I was gonna buy one, I was impressed, but then I realized I can't do it, so it's not too impressive. User error, it's not its fault. You can see the OCT on the top. The B scan's a really nice way, again, to look for geographic atrophy. And essentially what happens when you think about an OCT, right? An OCT is showing light into the eye. And when you have geographic atrophy, you're losing tissue. So the light is going to penetrate more in that area. So you get what you call a hypertransmission defect. So you see the light penetrating more in the area of atrophy. And you can see that on the top. FAF is it's a tool. It's been around for a while, but it's getting a little resurgence with geographic atrophy. And fundus autofluorescence essentially uses different wavelengths of light and different filters to look for lipofuscin. And lipofuscin is something that's released when the cells in the retina start to die. So if you see a lot of hyperfluorescence, that's retina that actually is undergoing damage, versus in the middle, the dark areas, that's hypofluorescence, that's already dead tissue. And the way it's helpful in geographic atrophy, if we see a lot of the light area, that means that's a lesion that's still active, that still has a potential to grow. So those are lesions that we start to think about might be really good for complement factor therapy, which we'll talk about in a second. And then the NIR, that's sort of the en face image on the OCT. Again, an excellent way to look for geographic atrophy and also check its progression. So again, here we are. You can see the retinal photography. I'm going to try one more time. Okay, look at that. Oh my God, I'm getting good at this. Good thing I'm not a surgeon, right? So there you can see a little bit of geographic atrophy there, but when you do the fundus autofluorescence, it really shows up much, much better. So small areas can be missed in color photo. Fundus autofluorescence is a little bit better. And then over here we see the en face images. On the top, you can see the progression, and you can see how the lesion is growing over time, and also how it's getting a little bit closer to the macula. So again, the en face is a really nice way to measure these lesions for progression, and we'll go over that a couple of times. AI, they're starting to use AI in certain systems in order to track the segmentation and the size of these lesions. The units I have aren't able to do that, but they're starting to do that. Here's another question that came out of that study that Nate was referring to, right? How do you manage patients with dry AMD? Select all that apply. And you can see that probably the three most common, which sort of makes sense: lifestyle modification, right? Talking to our patients about weight loss, smoking cessation. Smoking, number one risk factor, number one modifiable risk factor, I should say, for macular degeneration, including geographic atrophy. So uber important to talk to our patients about the dangers of smoking. Will they listen? I'm not sure, but I still think it's very important. UV protection, et cetera. Closely monitor patients through regular checkups. Obviously, that's important. You want to see, is it progressing? And if it does convert from dry to wet, you obviously want to get them treatment as soon as possible. Or, like we talk about GA, if you see that GA progressing, that's also a patient you might want to get treatment for. AREDS supplements, very, very important as well. There was a recent study that came out that actually showed that ARED supplementation, very important, not only in dry patients, but specifically patients with geographic atrophy. And you can see other things. Low vision specialists. I don't do low vision. Do you do any low vision? I don't, but it really is important. It really does help our patients if they unfortunately lose their vision or start to have diminished vision. It can really help them to send them over to low vision specialists. So if it's not something you do, if you have a patient you think can benefit, try to send them to a colleague of yours who does this, because it really can make a big difference. And you can see some of the other things up there as well. So one thing that you want to think about is when you see a patient, who's a patient that's high risk for geographic atrophy or wet macular degeneration. And again, because they got these medications FDA approved to treat geographic atrophy, we learned a lot in these studies. And we're learning more and more as we start to treat these patients as well. But we know baseline lesion size is important. And intermediate lesions probably grow a little bit faster than larger lesions. The way that geographic atrophy works is it tends to start outside of the fovea non-centrally and then work itself towards the fovea. So again, we know that extrafoveal lesions tend to grow a little bit quicker than foveal lesions right under the fovea. Multifocal versus unifocal, I think I said sure in the other picture, and I'll show it again in a second, but when you have multifocal lesions, right, you have more than one lesion, what happens, they tend to grow and coalesce and then form a bigger lesion. And those grow quicker than one single unilateral lesion. So that's always important too. There's other things too that have been shown in some of the studies. Low luminance defect. A lot of these patients will complain that they don't see as well in dim illumination. And really, when you think about geographic atrophy, using best corrected vision is probably not a good prognostic factor for how bad their GA is. Low luminance would be better, although we just don't do it in practice. But in a perfect world, it would be better. Lesions, locations towards the periphery and towards the fovea, we talked about that. Fundus autofluorescence, we're learning more about fundus autofluorescence. We do know that hyperfluorescence means it's an active lesion, but there's also certain patterns of fluorescein fundus autofluorescence that tend to progress quicker than others as well. Reticular pseudodrusen, I'll show you a picture of that later, is also a prognostic factor for patients that might get GA. And then reticular pseudodrusen and other things as well, and I'll show you that in a second. But the problem with GA is that it usually starts outside of the fovea, and really our goal is to make sure that it doesn't get into the fovea and then start to cause vision loss. So thinking about patients' vision isn't really the best way to think about GA progression, because really you don't get vision loss until it hits the macula, and by that time it's sort of a little bit too late to be thinking about treating it. You want to treat it before it gets into the macula. So it generally develops in the parafoveal macula and will march its way towards the fovea. And these patients will complain that they have a spot in their vision, they have trouble reading because they lose their place due to a scotoma, they don't recognize faces, things like that, but they may have very normal 20/20, 20/25 vision. So using best corrected visual acuity, not the best way to determine how bad someone's GA is. So I'm going to switch gears, and now I'm going to be Carolyn. So that's kind of fun. So Carolyn, unfortunately, couldn't make it today, but she's a great colleague, and she was able to send us her slides so we can go through her slides. So this is kind of, again, what I was talking about. You can see on the top you have a central or monofocal lesion. Those tend to grow a little bit slower than these other ones where you have multifocal, and then those multifocal little islands kind of get together and form, a bigger area. So they definitely tend to grow a little bit quicker. Smaller lesions tend to progress a little bit slower than larger lesions. Larger lesions tend to progress a little bit more quickly. So again, when you're looking at your patients with GA, you can use this to figure out, who do I want to send and who can I watch for a little while. Bilateral GA tends to be bilateral, although perhaps asymmetric. And it's always good if you see what happened in one eye, that's always, not always, but usually a predictor of what might happen to the other eye. So if you see really bad GA in one eye and just the start in the other eye, it makes me think I've got to follow this eye more closely because I see what might happen if we don't do anything. So using the other eye as a prognostic factor is really, really helpful. Again, we talked about this, and again, you can see the color photo, the fundus autofluorescence, and the OCT all are great ways to look for these lesions. They all have their pluses and minuses, but the fundus autofluorescence, sometimes you can really pick up the smaller lesions earlier than color fundus photos. Sometimes with color fundus photos, you have a lot of drusen with a little GA spot in the middle, and you can sometimes be overwhelmed by the drusen and miss the GA. But when you do the fundus, it pops out really, really nicely. And then this is what I was talking about here, this hypertransmission defect. You can see it right here. So the light will penetrate more, and you get the light showing through more, and you get this hypertransmission defect right there. Some people have called it a barcode defect. Some people have called it a waterfall defect. But I like the terminology hypertransmission, and I think that's what most people have sort of settled on. So when you see that, that's very characteristic of atrophy, specifically geographic atrophy. I really like to use the en face image as well to look at these lesions, because you can really see from baseline to 1 year to 1.5 years, you can really see that area superiorly, how it's growing with time. And there's some software out there. It will track the size of the lesion over time, and it will also track the area, its distance from the fovea. So you can use those to figure out, is it progressing? Is it getting closer to the fovea? Now, I have an older OCT. Mine doesn't automatically do it. You can do it manually, right? You can measure these lesions. You can measure the distance manually. It takes a little bit longer, obviously, but some of the newer OCTs have this software in there that does it automatically. It makes it very, very easy to follow, to notice progression over time. But I think even just looking at the top on-FOSS images, it's quite apparent there is progression over time. This really shows sort of the same thing. And on the top, again, you can see how much bigger that lesion is getting. And a lot of the lesions, they're foveal sparing, so they will save the fovea until the very, very end. So it'll kind of go around the fovea. Patients will have symptoms, but their vision might still be very, very good. And that's when we really want to start thinking about interfering before their vision goes bad. Here's one that unfortunately, again, the lesion got bigger over time, and then eventually it snuffed out the macula. So at the very last one, this patient here is going to have some vision loss because it's right in the macula. And what we really want to do is we want to prevent that from happening. So probably here might be a little late to be starting about therapy. We really want to start thinking about something here. Another example of a patient progressing over time, and again, you can see them progressing not only in the on-FOSS images on the top, also the color images on the bottom, as well as the OCT in the middle. And you really want to use whatever tool you have, as many tools as you have, because it does look slightly different in one modality versus the other. So in my mind, the best way to really look for this is whatever you have capable in your clinic, whatever you have, whatever you can use. Use that and really get a good look at it. Here's another patient for 3 years. Again, you can see that it saved the fovea until the very, very end, and now it's extrafoveal, probably a little too late to start thinking about therapy, unfortunately. So there's now 2 FDA-approved complement inhibition therapies for geographic atrophy. And when I first started to learn about this, I said, oh, great, that complement pathway that I never understood in undergrad, now I have to understand it. You really don't. All you need to know is complement causes inflammation, right? So one thing complement does, it causes inflammation. And they think that the reason you get GA growth is due to overactivation of the complement system. So you get too much inflammation, that inflammation leads to atrophy, and that atrophy will continue. So if you block the complement, if you decrease the amount of complement, you can actually slow down the growth of these lesions. This is from the pegcetacoplan, the study that got it FDA approved. They had 2 different studies, the OAKS and the DERBY, and the patients had slightly different types of patients and that sort of thing. But what you can see here is that the patients treated versus untreated, it actually slowed down lesion growth. So that's really the goal of these. They don't reverse any damage that's already happened. It doesn't miraculously give patients back their vision, but it slows down lesion growth and gives patients more time with usable vision. That's really the goal. So you can see from the OAK study about 22% at 24 months, and the DERBY study about 19%. So just about 20% slows down lesion growth. They found in the study that it actually worked much better in non-subfoveal. So the lesions outside the fovea actually had better response than the lesions under the fovea. So that's why if you find the extrafoveal lesions, those are really important to start thinking about treatment. The other thing that you can look at this is a 2-year, 2 years here, and you can start to see you get some improvement as early as 6 months. But the longer you treat these patients, you can see the separation between treated and untreated gets bigger and bigger. So the thought is the longer you treat these patients, the better off they're going to do in the long run. And this shows the same thing, 35%. They looked at certain types of patients and found that, again, the non-subfoveal actually respond very well. And out to 3 years, 35% reduction in lesion size. So about a third. So that's kind of good. Just in the sake of time, we don't need to talk about all of these. So early treatments based on the clinical data. I thought there was one slide, though, that I did want to talk about, but it's not there. That's okay. So if you see documentation progression, that's when you want to start thinking about sending it to the retinal specialist. So what I'm doing now is, and again, up until now, I didn't pay a lot of attention to GA patients because there was no really treatment. So what I'm doing now, if I see a patient with GA, I'm going back and I'm looking back in their scans and saying, hey, has this progressed over the last year, year and a half, 2 years? And if I see progression, I'm starting to think about this might be a patient that I might want to send to my friendly retinal specialist to at least think about should he get this treatment. So I really start to think about the extrafoveal ones, the ones that don't hit the fovea. Once it gets in the fovea, it's sort of a little bit too late. So I think patients that have already lost vision in one eye and you see change in the other eye, that's an ideal candidate, right? Because they know what's going to happen if they don't do anything, and you can recommend some treatment to slow down the progression in that one eye. Obviously, these patients, it's an intravitreal injection, and usually it's every month to every 2 months. The studies seem to show that every month is a little bit better, but a lot of patients prefer every 2 months just because of the hassle of getting into the doctor. So some retinal specialists do it every month, some do it every 2 months. Really depends on the particular patient. So it is an injection, so you do have to explain that to patients. You explain to patients that it's not going to fix everything, it's not going to reverse the damage they already had, but the goal is to slow damage moving forward and hopefully leave them with longer time with usable vision. So you want to use it for the appropriate patients, and with that, you're going to get the best results. So I think it's really important to have that discussion with patients ahead of time, because if they don't have reasonable expectations about what the treatment does, they're going to be a little bit upset, right? So you do have to explain to them that it slows the progression, it doesn't stop it in its tracks. Vision can still get worse even with treatment, but again, the theory is if we don't treat it, the vision loss would be much more accelerated. Intravitreal injection every month to every other month. It's chronic therapy. They're going to need injections for a long period of time. And my patients say, well, I need them forever. And I tell them, it's a little too early. We don't know that yet. But plan on at least the next couple of years. Yes, you're probably going to need serial injections for the next couple of years in order to maximize the benefit. So it really is important. Some patients don't want to do it. When you explain to them, it just slows down the progression. They're not that interested in it, and I get that. But I think we at least have to have the discussion with the patient to educate the patient so the patient knows what their options are. And I just had a patient late last week that I wanted to send out for therapy. We had a big, long discussion, and I basically tell them it slows down the lesion growth by about 25 to 30%, right, if you look across all the different studies. So 25, 30%. And this patient said, well, I wish it were more. And I said, so do I, right? I wish it were more too, but this is the first iteration of drugs. Probably with time, some smart person will come up with something even better. But I told this patient, I said, but 25%, it's still pretty meaningful. That's still a pretty significant number. And if someone told me a couple years ago that I could do something to slow down my hair loss by 25 to 30%, I would have done it, or I should have done it, right? Yeah. So it's not perfect, but it's a start. So let me go over a case here real quick, and then I'll pass it over. But this is a very common patient with geographic atrophy, a 70-year-old male, has a lot of other health issues. You can see them there. These are older patients. They have a lot of cardiovascular issues, which probably tie into their geographic atrophy as well. Patient never smoked, which is good. 20/20 vision in both eyes. But you can clearly see all the drusen in there in this patient's eye. And for sake of time, we won't get through all this. But you can see now this patient progressing over time from baseline to 1.5 to 3. And in the 3-year, you can clearly see there's really a nice area of geographic atrophy right there. And you don't really see it as much here. So this patient's really progressing over time. It's probably worth having a discussion with this patient. Would one of these new treatments be good for you? And you can see here, just this area is really getting bigger as time goes on. You can also look again on the bottom. on the on-FOS images, again, you can see that the smaller lesions, and it's very hard sometimes to see these lesions, right, in the color. You can really miss them because they're hidden sort of by the drusen. And you're thinking about keeping an eye on these drusen, and then you say, oh, there's also geographic atrophy, which I got to look for, and we can see it's getting worse, right? They're growing, and they're getting closer to the macula. So this might be a patient that really should have a discussion about it. Fundus autofluorescence, we talked about that. And again, you can see those dark areas. The other thing I like about the fundus autofluorescence is it's a nice way to explain to the patient why they're having the problems they're having. I can say, you know, Mrs. Jones, the reason you're getting those little areas you can't see well is because this little tissue is dying. All those black spots is dead tissue. That's why you're noticing those little blind spots when you're trying to read or play cards or whatever the issue might be. I'm going to pass over to Jessica, but just real quick, you know, every treatment does have potential side effects. One of the biggest side effects with this is conversion to wet neovascularization, right? So these patients do need to be monitored closely because a certain percentage in this study was around 11% in the treated versus, I think, like 3% in the untreated. So there is increased risk of choroidal neovascular membranes. They do need to be monitored for that, and obviously if there is any sign of that, then they need treatment for that as well. So with that, I'm going to pass it over to Jessica.
Thank you.
You got it.
So this is such a good collaborative discussion. When we talk about geographic atrophy, you know, I hope some of those little bells, those signs were going off to say, what does this really sound like that we're familiar with as far as management? When we talk about GA, there are so many features of risk assessment, detection of disease, and then detection of change over time that mimic what we do when we're evaluating the suspicion of glaucoma, the diagnosis of disease, and monitoring for progression. So this is certainly within our wheelhouse as optometrists to, of course, not just diagnose and refer, but diagnose, understand, assess the risk, to make really well-educated referrals and to work with our patients as they're undergoing therapy. So really a timely, good discussion in connecting these two seemingly very different disease states with similar features related to management. Now, when we look at the survey from 2024, how many glaucoma patients do you see each month? The majority, 1 to 10. You know, the stratifications are a little bit different in dry AMD, but when we look at 1 to 20 in our dry AMD population in our practices, 1 to 10 as the primary in optometry, you know, we're seeing these numbers increase. I think that's one of the biggest takeaways is that depending on the environment that you are in, no matter the environment that you're in, glaucoma is becoming more prevalent. Our tools, our technologies, and our understanding of the disease is also improving to detect disease earlier. Glaucoma prevalence around the world is increasing. In the United States, it is significantly increasing. We also understand that individuals that are at greatest risk for vision loss due to glaucoma are more likely to be of different ethnic background. Individuals who are Black or African American are at significantly greater risk of vision loss in their lifetimes. So we really do have to think about our patient population, the importance of early detection and education through the treatment process. You know, this is not a diagnose and treat one and done, another chronic therapy where real understanding of the disease process and the need for long-term therapy becomes so important in long-term patient success. So if we think about early diagnosis and early detection, it starts with optic disc assessment. Truly, this is primarily in a primary care optometry environment where it begins. You know, you're already starting to put the pieces into play based on the patient's history, family history, systemic risk factors, but we understand that intraocular pressure is a terrible screening tool for the diagnosis of glaucoma. Just because someone has statistically elevated intraocular pressure, that doesn't mean that that is physiologically abnormal for the person. That's ocular hypertension. And just because someone has statistically average or normal intraocular pressure, that doesn't mean that it's not physiologically abnormal. We understand that realistically about, again, 50% of individuals in the United States may have a glaucoma diagnosis who don't know about it. We do also understand that overdiagnosis of glaucoma is also a challenge, which leads us back to our clinic to say, how can we use the tools and technology that we have access to in accurate determination of disease? And it's not something that's often easy. You know, we look at this particular individual. He had been referred by his primary care optometrist for further evaluation annually for about 3 years before he finally said, okay, I guess I should go. You know, this is someone who doesn't have statistically elevated intraocular pressure. His primary care optometrist did the excellent job in assessing the optic disc accurately, making the determination. And you know, it took that 3 years of discussion for the patient to finally have that aha moment that maybe I should have this evaluated further. And I'll say that he's one of, I'll say, my most interesting patients to take care of because he is that skeptical personality. So I can see where it was the feat to even have him enter the office. It's been a feat for him to initiate treatment, and now he's maintained really good buy-in, understanding of the process, and we're now about 2 years into treatment in my office as well. Now, when we look at beyond intraocular pressure, which we know, you know, if it's high, that makes it easy. That's a slam dunk. We're going to investigate further. But what about when the intraocular pressure is statistically unremarkable? What else do we look at for early disease? Retinal nerve fiber layer analysis right at the top with visual field testing. One thing that I think is interesting here, just to bring up, is the difference in the retinal nerve fiber layer analysis and ganglion cell analysis. Now, we do use both. It's not about one or the other. The retinal nerve fiber layer analysis, yes, we have 100% of axons that are being evaluated, in addition to inclusion in that thickness of glial tissue and retinal vasculature. When we look at the ganglion cell complex, ganglion cell interplexiform layer, or ganglion cell layer itself, this is not 100% of the ganglion cells of the cell bodies. We're really about 30%, but we've got this high concentration in the macular area. These are two imaging techniques that do pair well together and should be utilized together. So I'd love to see for future that ganglion cell analysis increase to the same level of retinal nerve fiber layer analysis. Other things that came up, interestingly, in this evaluation, in this survey, corneal hysteresis, ERG, genetic testing at 1%. Now, we do have a cleared genetic test in the United States. This is not something I've used yet clinically, but I've been very curious about. The goal is not to diagnose disease, but to understand that patient's genetic risk when there may be additional risk factors at play. Again, it's about more data, incorporation of more data, and real risk assessment.
Jessica, I think the important point on this slide. Am I on? There we go. All of these numbers should go up. Would you agree with that? Like, in glaucoma, do we have one perfect test? The answer is we don't, and we need to have OCT and ganglion cell and visual field and corneal hysteresis and all of these tests to give us the best idea, structure, and function. Do the testing, do it again, and do it again to get more data.
Evaluate, and this is where, as optometrists, this is the fun, this is the challenge, that it's not just about evaluating the test on a single day. It's evaluating, as you said, Steve, over time, really watching for change over time. Let's go back to this initial baseline and watch for subtle change. So we can look at, again, retinal nerve fiber layer analysis, ganglion cell complex, and we're looking for patterns. You know, I've removed much of the reference database information. When we're looking at retinal nerve fiber layer and ganglion cell analysis, you know, we have the red, green, yellow, depending on the device that you use to compare to a reference database. Sometimes there can be challenges, as our patient that we're imaging may not be well represented in that reference database, which may make the scans come out more red than you expect, or green and look like they may be normal when there actually is early pathology. So again, what we're looking at is patterns, and we see this individual has retinal nerve fiber layer loss, superior temporal, that correlates really well with the ganglion cell complex. Now, regionally, we talk about, is that a squeegee sign? In Florida, we like to use nautilus shell sign, horizontal raphe sign, I don't know, maybe window scraper sign, depending on where you are in the country. But we're looking for correlation. Now, other tools and techniques, of course, we're looking at the optic nerve. We are imaging the optic nerve. I still take fundus photographs once a year in patients looking for structural change. This is, again, one technology that doesn't change over time. As we upgrade the technology in our offices, we have to keep in mind that if we're upgrading or changing to another manufacturer, what happens to our previous data? Often it cannot and will not be able to be integrated into your progression analysis. Fundus imaging doesn't change. Visual field testing, we can have a full hour conversation on new devices, new strategies. This happens to be the 24-2C CETA-FASTER, an additional 10 paracentral points. Not a replacement for our 10-2 visual field in this particular patient, certainly. The 10-2 still provides important information, but the 24-2C allows us that additional paracentral information on top of our 24-2 scan. So let's briefly look at this case. She's 68. I like this case. She's new. She just came in a couple weeks ago for the first time. And she had said, look, I've been a glaucoma suspect for the last 30 years. I've got deep optic cups, but it's not glaucoma. All right, so 68-year-old female. She is pseudophakic. She's 20/20. Pressures are 16 and 17. Corneas are thin. Risk factors systemically. Type 2 diabetes mellitus. She has COPD. All right, when we look at her optic nerves, these are large optic discs. If we look at the right, well, the neuroretinal rim looks well intact. If we look at the left, it's a slightly different appearance of the optic nerve. And there's some suspicion superior temporal. If we look at our retinal imaging, now she's not perfect. This doesn't fall within a perfect normative range, but this is where we've got to filter out how is this person reflected or not in a normative database, and how can we differentiate that from the type of pathology or the type of pattern that we expect in early disease. Now, I'd say the right eye overall is within range that I expect to be normal for this woman, but if we look superior temporal, just looking at the raw data, the retinal nerve fiber layer, not as robust superior temporal. And is that an early squeegee sign? Now, is this changed? Is this new? I don't have past records on this woman, but this is realistically the shift, the transition, the development to early disease in this right eye, and there's additional evaluation testing that needs to be performed. Next on our list, of course, is a 24-2C CETA-FASTER, but this is someone that we are now leaning towards treatment on.
Well, and fortunately, Jessica, we've got time a lot of times in glaucoma. We can get more data 4 months from now, 3 months from now, 6 months from now, whatever it is. Repeat that OCT, repeat the ganglion cells, get another pressure reading, let's get a visual field. Where is that pressure range at? I told that patient yesterday that I was on the phone with when I was driving home from the airport we have some time. She has 5 siblings, and all 5 of them have glaucoma. All 5 have been diagnosed. She was the last one that had not been diagnosed with glaucoma at this point, and she's concerned that she's going to go blind like her brother did. And she goes, well, my brother really never took any of his drops that he was prescribed over the years, and we'll get to that in just a little bit. But I told her, I said, we have time here. You're not going to go blind today, this week, this month. Glaucoma, generally speaking, there are exceptions, is a condition of years and decades. So repeat the data. Let's do some more. So let's talk on management. So again, when I looked at this case, again, it was Jessica's case, I looked at this and said, I think this patient has glaucoma. I mean, I think it's pretty straightforward that they have glaucoma. We can repeat the testing, and we may pull the trigger 4 months from now. It depends on other variables. But let's say this is your patient, and they have glaucoma. How are you going to treat them? The vast majority of you, 86%, said, I'm going to put them on some sort of medication, and we know that IOP is the main modifiable risk factor that we have when treating patients. Whether it's laser, whether it's medications, whether it's surgery, whether it's drug delivery, we are lowering the intraocular pressure. Now, how do we do that? Well, traditionally speaking, your first-line therapy is what? is a drop and usually a prostaglandin. And that enhances what? Uveal scleral outflow, which is the secondary pathway of IOP reduction, responsible for probably 20 to 25%. That's the main pathway, the conventional outflow pathway that is really responsible for 75 to 80% is what the literature tells us. So if we can address that conventional outflow pathway, that may be beneficial along with other ways as well. Maybe we match the uveal scleral and the conventional outflow. So again, resistance can happen at 3 levels. The level of the trabecular meshwork, the level of Schlemm's canal, and those collector channels as well. And again, all of these can work on this area. And we're going to talk about each of these in just a second. Medications have been first line for a long, long time. I've done a lot of glaucoma lectures, and I've polled the audience and said, what is your go-to first-line therapy? And the answer is usually a prostaglandin analog. I think you guys would probably agree with that as well in the vast majority of patients, and it increases uveal scleral outflow. We have other medications as well, like beta blockers that decrease aqueous production, and we have some medications that are relatively new within the last 5 to 10 years. Your Rho kinase inhibitors, your ROCK inhibitors, they're also known as, products like Notarsadil that work on multiple different mechanisms. As little as 5 to 10 years ago, we didn't really have a medication that increased trabecular meshwork outflow. We had medications that increase uveal scleral outflow, as you guys know very well, and have medications that decrease aqueous production that you guys know very, very well. But we have medications now that we can hit it in different ways. And we have the Rho kinase inhibitors, the ROCK inhibitors. They also have a component of NET or norepinephrine inhibition as well. And these work in different ways. These can increase trabecular meshwork outflow. Do they pair with a medication or a laser that increases uveal scleral outflow, specifically prostaglandin? So these increase trabecular meshwork outflow. They lower episcleral venous pressure. What is episcleral venous pressure? It's that backstop pressure. Can you guys get the pressure in your patients with medications to 5? To 4? We can't, because there's a backstop pressure there. Unless they have a tube or a trab, there's going to be an episcleral venous pressure. That's why it's hard to get the pressure below 8 to 10, because of that episcleral venous pressure. Well, we have medications now that not only increase trabecular meshwork outflow, but lower episcleral venous pressure and can decrease aqueous production as well. So again, just hitting in different ways as we try to lower that intraocular pressure. So medications certainly historically have been first-line therapy. You've heard me lecture before. You guys know I'm a big laser fan. Selective laser trabeculoplasty. I practice in Oklahoma. We do a lot of SLTs. That's why that patient called me yesterday. She said, my local doctor said they're probably going to refer to you, Dr. Nate, to have a potential an SLT. This has now been proven because of the LIGHT trial, among many, many others, to be a first-line treatment option in open-angle glaucoma ocular hypertension. I encourage you guys to look at the LIGHT trial. It released data in 2019. It released more data in 2022, and this is what it said. SLT not could be, should be offered. Not could be, should be offered as first-line therapy for open-angle glaucoma and ocular hypertension, supporting a change in clinical practice. That's exactly what the conclusion was. Those are big words, supporting a change in clinical practice. What did that mean? It means gone are the days of drop 1, drop 2, drop 3, and maybe drop 4. We're going to talk in the next 5 to 10 minutes on interventional glaucoma. What is interventional glaucoma? It means we're going to take some of the burden off of that patient. So they're not taking 2 drops, 3 drops, 4 drops. I'm guessing you guys historically agree, over the last 50 years, wasn't it put them on 1 drop, and then put them on a 2nd drop, and then probably put them on a 3rd drop, and then, God forbid, you have to put them on a 4th drop. It's been 2, 3, 4 drops, but now we have a laser that's first-line therapy, so they don't have to take that drop day in and day out. This patient yesterday told me, she goes, quote, I've been on it for a week, and I'm already tired of my eye drop. So again, it just shows the burden that we have with some of these patients, and you guys may or may not know that there are new versions of this SLT out now. How many of you have heard of DSLT, direct SLT? Anybody? This has been studied and is now FDA approved of automated direct transscleral SLT. What does that mean? Automated. You hit a button and it automatically tracks the eye and fires the 120 shots for you. As I've done SLT over the last 15, 16 years, we usually put around 100 shots in there, but you have to hit the button 100 times as you go all the way around with a gonioscopy lens or an SLT lens on the ocular. This is automated now, okay? Automatically fires the shot. What does direct mean? No lens on the eye. No lens. This is direct transscleral. Fires 120 shots right at the limbus, through the sclera, transscleral, and it's called DSLT. Takes me usually on average between 2 and 4 minutes to do an SLT per eye. This new version of SLT, automated direct transscleral SLT, you hit the button, treatment complete in 2.4 seconds. 2.4 seconds. This is now available in the United States, and it's very, very early. We're in our infancy stages of that, but again, laser is becoming a more prominent role. You have 2 wonderful first-line options, meds and SLT. Show of hands, how many of you have patients that struggle with glaucoma medications? And all of you can raise your hands. And I tell them, we're going to make the decision together. This may be a great option for you, these medications, or this laser may be a great option for you as well, Mrs. Jones. And you guys are the experts. You make that decision together, what's best for the patient. And now we have MIGS as well. You know, I told that patient yesterday, we're going to take advantage on that snapshot in time when you're having cataract surgery, or even when you're not having cataract surgery, we can have standalone MIGS. And sometimes they're stents, as you can see here. And again, there's data is overwhelming in the MIGS space, whether it's a stent, whether it's a canaloplasty, all these different devices. What have they shown? That when patients have MIGS procedures, they're on less medications and their pressure is lower. Do you want your glaucoma patients to have lower pressures on less medications? That's a win-win. If we can get them on less meds and a lower pressure, that's win-win. And the other thing I wanted to call out on this that really stood out to me is this broke the data down based on all of the patients and based on IOPs greater than 22. So all the patients in the study, and then let's just look at a subset when the pressure was greater than 22, and notice when their pressure was higher, 100% of patients in this study had greater than 20% IOP reduction when their pressure was above 22. The same thing holds with SLT. You know what the biggest predictive factor for success is with SLT? Pre-laser IOP. The higher the IOP, the more bang for your buck, the more drop in pressure you get. Same thing with MIGS. The higher the pressure, if it's greater than 22, every one of those patients had a nice pressure reduction, on average almost 10 points. That's a 41% pressure reduction. So look at pressure. Yes, it's not a great tool, but we got to look at it. We have to look at it in these patients there. And again, there's different types of MIGS, subconjunctival MIGS that are a little bit more aggressive and a little bit more invasive as we're looking at this. MIGS is a balance of how much do I need to lower the pressure and what's the safety aspect. Stent versus the superciliary versus these subconjunctival ones. Again, there's different devices on this. All of these lower their pressure, but it's a balance of how much do I want the pressure to lower versus the safety aspect as well. So what percent of your glaucoma patients would you estimate are candidates for minimally invasive glaucoma procedures? You can see the results in this survey from your colleagues. You know, what percent of your glaucoma patients would you estimate are candidates for MIGS procedures? You know, I would argue it's probably that. It's got to be higher than that. It's maybe nothing's 100% in medicine, but to me, this should be the number one answer of more than 40% because of this aspect of interventional glaucoma as we're talking about. How many MIGS patients do you co-manage each year? And you can see how many MIGS patients each year your colleagues are co-managing. Again, I think this number needs to go up as we consider more and more interventional glaucoma. Direct treatment versus co-management. Again, we've already addressed this already, the interventional glaucoma of taking that burden out of the patient's hand there. So in our last 5 minutes here, we're going to talk a quick case, 61-year-old male. This is a patient that came into our clinic. He was diagnosed with glaucoma in 2016, right eye worse than the left eye, was started on a prostaglandin analog, had an SLT, and isn't this glaucoma? You ready? Watch this. No care from 2017 to 2021. Despite the best efforts to come back, we'll see you every 4 months. Let's check your pressure. Let's follow up on the SLT. I'm sure he's still taking that prostaglandin 4 years later, don't you think? You know, obviously he's not, but that's glaucoma. It's what we deal with. And I was worried. The first time I saw him was in August of 21, and I'm like, what are his pressures going to be when you haven't been taking your medications? He said, I haven't taken my medications in years. And he came in and his pressures, there's his visual acuities, 20/25. And the day that I saw him, again, this is the first time that I saw him, was August 31st. His pressures were what? That's not bad. You know what I said here? Thank you what? SLT. Thank you, SLT, that we've had that on board for this period of time. He had some grade 1 nuclear sclerotic cataracts. There's the nerve in the right eye. Give you a better view of that nerve in the right eye. What do you guys think? Yeah, it's a typical standard 0.2 cup, don't you think? You know, if the student comes in and says that's a 0.2, we're going to have a conversation that day, aren't we? This was significant cupping in the right eye. And look at the asymmetry. There's the left eye. Which test is very, very important when you have nerves that look like this with this degree of asymmetry? Jess showed the slide here of all the different tests that are being done, and this one was at about 45%, I believe. What test is very important when you have this degree of asymmetry? Gonioscopy. You've got to do gonioscopy. Now, in this case, it was non-contributory, but you've got to do gonioscopy. I was involved in a case a couple of years ago. I was contacted by a lawyer and asked by the defense, you know, when there's a litigation case, they get expert witnesses on both sides, the plaintiff side and the defense side, and I was contacted by the defense to review the records, and everything in this case hung on that gonioscopy was not done when pressure was 30 and 18, 28 and 21, 27 and 20, 29 and 19, asymmetry over multiple visits, and when gonioscopy was finally done about 8 years later, showed 270 degrees of angle recession, and there was significant progression, and the patient sued that doctor because she had lost usable vision. Gonioscopy. Don't forget about gonioscopy, especially as we do more and more SLTs as optometrists. This was that patient's visual field. You know, you showed you the significant cupping in the right eye compared to the left eye. Right eye versus left eye. There was the visual fields, significant. So go back to that case. He goes, so did you help the defense? The key here was when they saw this patient and said, come back in 6 months, the patient no-showed. Patient came back 25 months later, and in that 25-month period, the pressure between 28 and 35 is where their range was. They had significant progression. So is it the patient's fault because they didn't come back? Now, I defended that and said, you know, they had needed to come back on this, but there was still some fault there of not doing gonioscopy. It took another doctor one visit to see that patient. They did gonioscopy in the first visit and finally diagnosed angle recession. So again, there's multiple variables in that particular case. OCT, you know, at the end of the day, what worked best for this patient? Was this patient compliant, this 61-year-old male? Was this patient compliant? Nope. He had an SLT done before. We managed this patient with a combination of SLT, and he had cataract surgery and a MIGS procedure. Again, that interventional glaucoma, as we've talked about already.